So this is the third video, live streaming presentation video in my topic today about fluid and electrolyte balance, the fluid and electrolyte management. So as I mentioned, these are the I just finished in my second streaming with the disorders or causes of electrolyte imbalance and the fluid imbalance, and I mentioned this might be due to excessive loss or improper intake or organ diseases like kidney disease, acute or chronic, respiratory disease, especially chronic respiratory diseases with hyperventilation, also adrenal disorders also, they might be among the causes of fluid and electrolyte disturbances, or changes in the pH of the internal environment, especially in patients with metabolic alkalosis and metabolic acidosis with disturbances in the shift of sodium and the potassium between the internal and the external compartments of the body. So changes in the pH also, especially metabolic alkalosis and metabolic acidosis, are related to disturbances in fluid and electrolyte balance. So all of these are disorders of or causes of fluid and electrolyte balance. And as I mentioned, the most common form of fluid imbalance is hypovolemia, but there are also, as I mentioned in my first episode, there is what we call normovolemia with maldistribution of fluid between body fluid compartments, and also there is hypervolemic states or water overload states or water retention states or excess water states of the body, as what happens in organ failure, especially heart failure, renal failure, and chronic liver cell failure with water retention. So causing, of course, generalized, these are among the causes of generalized water retention in the interstitial tissue, causing edema, peripheral edema, or also in accumulation of water inside the serous membranes in the pleural space, in the peritoneal space, that's ascites, pleural effusion, ascites, and pericardial effusion. So this is what we call the hypervolemic states or the water retention states. But I mentioned that the most common is the hypovolemia, which we see in, or the hypovolemic states which we see in clinical practice due to either loss of blood or loss of plasma or loss of water from the body, and I mentioned that loss of blood in hemorrhage, external or internal, loss of plasma in severe burn patients, loss of water in excessive urination or excessive diarrhea or vomiting, severe diarrhea, severe polyuria or polyuric states, severe respiratory disorders, in febrile disorders, especially acute febrile disorders with loss of sweat, because the sweat, the saliva, the tears, and the vaginal secretion and the gastric secretions, they are other body fluids, but these fluids they present to the outside of the body, and also they might disturbances in such fluids might be seen clinically as some fluid balance disorders, or maybe also the cause of some hypovolemic states. In hypovolemia, which we see in clinical practice in the emergency room or in the ICU, number one is in the fluid resuscitation or intravenous fluid resuscitation is to replace the lost fluid. This is an important principle in what we call intravenous fluid resuscitation, which is important in cases of hypovolemia. and also in patients who are hypervolemic and in patients with normovolemia with maldistribution. There are principles in which we should follow in the fluid replacement in such cases. But let me first talk about intravenous fluid replacement in hypovolemic patients, because this is the easiest and this is the most common, and we can restore the fluid balance easily if we follow the simple rules of intravenous fluid resuscitation in hypovolemic states. If the hypovolemia is due to blood, we replace blood, whole blood. Or if whole blood is not available, we can give back the RBCs with plasma transfusion. So whole blood is the best fluid in patients who lost the blood. In patients who lost the plasma, like burned patients, we give, of course, plasma transfusion, so intravenous plasma. In patients who lost water, vomiting, diarrhea, polyuric states, etc., we give usually we give saline, intravenous saline. To give it a normal saline or half normal saline, or that's hypotonic or hypertonic saline, it depends on the case. When I will talk about the selection of intravenous fluids in fluid replacement cases, I will discuss this issue and the details of which type of fluid to be given, that's crystalloids, because we all know that intravenous fluids which we give are either colloids or crystalloids. Regarding the colloids, are like the blood and the plasma. The crystalloids is like the saline with all its types, the hypertonic, the isotonic, and the hypotonic saline. And dextrose with all its concentrations, the catalyx and potassium containing fluids, the Ringer's solution, and the normal Ringer and the Ringer lactate with all its also concentrations. These are the crystalloids, and the selection of crystalloids also has wisdom in clinical practice, and the type of fluid or the type of crystalloid used varies with the individual fluid imbalance, which is variable from case to case in clinical practice. So there is no one crystalloid for all patients who are dehydrated or who are hypovolemic. The selection of the crystalloid depends on the underlying cause and depends on the clinical presentation of the patient. And usually the mistakes which are done in clinical practice in fluid replacement and in intravenous fluid management is due to misunderstanding of the pathophysiology of each individual case of fluid imbalance or electrolyte imbalance. So we have to identify the fluid imbalance and the electrolyte imbalance blamed in every individual case in order to tailor which fluids we are going to give to every case, especially as regards to the crystalloids or the intravenous crystalloids which we are going to give in patients with hypovolemia or patients with normovolemia with maldistribution of fluids. We have to understand the pathophysiology of the fluid imbalance and of the electrolyte imbalance in order to be able to understand which fluid we are going to give and which fluid will suit the patient, each patient the best. It depends on the clinical circumstances and the underlying pathophysiology. In order to minimize mistakes of regarding the intravenous fluid management and intravenous fluid resuscitation in different cases. So these are the general rules and the general principles which I wanted to clarify and to highlight in fluid and electrolyte balance and fluid and electrolyte management. In further future episodes, I will explain in detail and talk more in detail about such issues, especially about the hyponatremia, which is the commonest electrolyte disorder,